medical students get almost no, well, in fact, get zero training in menopause. And the women who are not struggling are clearly doing everything right. No, I'm sorry, that's just the luck of the draw as far as from what we know. So the type of HRT that you would get from the NHS, these are hormones that are produced from plants. So they are natural and they are identical.
Welcome to the Visionary podcast, where we discuss science, medicine, physical health, and mental well-being. The 2002 Women's Health Initiative study caused fear and confusion about hormone replacement therapy. What happened in that study?
So this is, I think, the basis of a lot of people's fear of HRT. And that is not just fear in women who might want to take HRT, also fear in many doctors. So before that study, women had been taking HRT for a long time. And remember we talked about the impact of HRT on cardiovascular health and bone health. A lot of the studies of HRT before that, this WHI study had demonstrated that in women who start HRT within this window of opportunity, which is between the ages of 45 and 55, at a time when they still have the effects of their natural estrogen, because they are in the menopause transition. They haven't stopped producing estrogen completely. So what giving HRT during that time does is that it just prolongs the effects of their natural estrogen. In those women, HRT, apart from relieving symptoms, also reduced the risk of cardiovascular disease, reduced the risk of osteoporosis. This was well known. What was not known was whether estrogen was of benefit to older women. And so this study, older, so age? Over the age of 60, basically.
Okay.
And so this study set out to try to understand that. And what happened in that study is that the majority of women, and there were over 10,000 women in this study, the majority of women in that study were women.
Sorry to ask, is 10,000 in terms of clinical research?
That's a good sample.
Okay.
Yeah, that's a good sample. You can, so, and it's a good question. So sometimes when you see research published, they'll report a good result and they'll say, oh, we studied 10 women. 10 women is not a good sample.
Okay.
There might be many things about those 10 women that are very different from other women. But when you have a big sample, a sample of over 1,000 women, for example, then you can get a diversity of women and then you can kind of draw conclusions, hopefully for the majority of them, from them that would be adaptable to the majority of women, depending on the population. So this was a good sample. And what happened was that they recruited into this study many women, the majority, I think 70%, who were over the age of 60. And the reason for doing this was because, we can see that in younger women, in the menopause transition, the HRT is beneficial. So let's see if it does the same in older women. And in retrospect, what happened was they included women in the study who we would never normally have given HRT to now. So one of the reasons that estrogen is protective is because it reduces the risk of cardiovascular disease. But if you already have established cardiovascular disease, which you're more likely to if you are older, then estrogen may not be helpful. And there was some evidence that estrogen is actually potentially harmful when you have established heart disease. That's a bit controversial now. And it's possible actually that estrogen in women who are over the age of 60, if they don't have any other heart problems, may be neutral. But this is where the concern about giving people HRT over the age of 60 comes from. Do they already have some heart disease? Because estrogen will not reduce or reverse heart disease that already exists. So that was one thing. There were women who were really, really very overweight, who potentially should not have had that kind of HRT because this was oral estrogen, which may bring problems with it that transdermal HRT or HRT through the skin does not bring. The study was started and they found that women in that study who were the women who, so it was a randomized study. So some women got HRT and some women didn't. And in the group who got HRT, there were higher rates of heart disease and heart attack and stroke and higher rates of breast cancer than in the women who did not get HRT.
Was it a 50-50 split
I
between them?
can't remember, but I think it was something similar, but I can't remember exactly what the split was.
Yes.
And so they immediately, having seen more women having heart attacks and strokes and more women having breast cancer, decided that HRT was harmful. What happened, though, is that they also included in that study some women who were in the age range where we knew that HRT was beneficial. And what they should have done was that they should have separated the younger women from the older women and analyzed them separately. And they didn't. They analyzed everybody together. And then the harm that they saw, they decided was harm to all women. And it's only really been in the last 7 to 10 years that they have separated the women and analyzed the older women separately from the younger women. And in the reanalysis, looking at the younger women, they did not find that harm. What they found was the same as they had found before that study, that in women who are under the age of 60 or within 10 years of the onset of menopause, HRT is beneficial for the majority.
Yeah,
but this changed people's views of HRT. And many millions of women who had been taking HRT and doing well stopped taking it because they were frightened. Many women who might have wanted to take HRT and would have benefited from HRT refused to take it, and many doctors stopped prescribing it. And it was a big disservice to women.
Yeah, that makes sense, because women in their reproductive years are different than perimenopausal, than menopausal, than 60. Yeah, they have different health challenges.
Exactly.
And having said that, if cancer is not a prevailing risk for the majority of women, why is the leaflet of my estrogen treatment full of cancer doom and gloom? It's as long as an arm.
Yeah. So it's partially based on that study. So that study influenced so much. But you may have heard recently, controversially, that the FDA, the Food and Drug Administration in the United States, that is an important regulator of medicines, has now asked for the label on HRT to be changed to remove that risk. It's controversial because there are still some women for whom HRT may not be suitable. But I think that overall it's a good thing, because it means that the fears that this review of the WHI study have sort of helped to address can now be reflected in what is on the label of estrogen. But it's really, really important that women have a conversation with their healthcare practitioner about the real benefits and the risks, and that people don't just say HRT is safe for everybody, because it is not safe for everybody. There are some people for whom it isn't safe. So you still have to have the conversation. So I don't think that the change in the label, for example, will change my practice in any way, because I always have a conversation. I think it's really important that women don't take away from this that HRT is safe for everybody, because there are some people for whom you have to be careful.
Hi, I'm Hala, your host today. If you're enjoying what you see, please hit that lovely subscribe button. It will mean a lot to us. Or maybe a small podcast now, but with your support, we can build this channel together, one step at a time. Thank you so much for being part of it. I have a bit of a vague question. What don't we still know about HRT? Have we figured it all out now?
No, I don't think we've even nearly figured it out all now. I think we understand a lot. We understand about I think we understand a lot about the mechanism for how it works and so on. I think what we don't understand is why different women respond differently to it, why different women respond differently to different HRT preparations. We are all very individual. And as you know, there is this move towards individualized, personalized medicine. I think we need much more data on the way HRT behaves in different women's bodies to be able to properly individualize or personalize medicine, HRT. So I think we have a long way to go, but I think that's what we should be aiming for. So I'll give you an example. So as you know, transdermal estrogen, so estrogen that you give through the skin, either as a patch or a gel, works really effectively and actually gets over some of the risks of some types of oral estrogen. So for example, oral estrogen may be associated with an increased risk of blood clots, for example, whereas transdermal estrogen is not. So if you have a history of blood clots, we would normally prescribe transdermal rather than estrogen, oral estrogen. But for women who take transdermal estrogen, why is it, for example, that after they've used it for a while, suddenly they find their symptoms come back? So we know that there is some data to suggest that some women stop absorbing it so well. Why did they stop absorbing it so well? It's not understood. Why is it that some women who have their estrogen as a patch find that helps their symptoms better than women who have it as a gel? What is it? What happens under the skin or between the skin and the sort of blood circulation that changes the way HRT behaves? So there are all of those sorts of things. Are there some populations in which some types of HRT work better? Are there some populations? I don't know. There's a lot.
Lots of questions to be asked.
Lots. And I think, and this comes back to this thing about, I think, women sometimes doing themselves a disservice, because there are some women who, so why is it that some women sail through menopause with no problems at all? I mean, I don't mean the ones who have problems but don't talk about it for whatever reason. I mean, women who really are not troubled by symptoms. Why is it that there are these differences? What is it about those women compared to women who really struggle? And why is it that some women need different doses of HRT? And that may just relate to, I think that relates to the fact that we are all very different. So, but the point I'm making is that there are some women who really just are not troubled by menopause, who sometimes sort of look down on women who are troubled, as if the women who are troubled by menopause are weak or not doing something right, and the women who are not struggling are clearly doing everything right. No, I'm sorry, that's just the luck of the draw as far as from what we know. There are some people who really struggle in life for lots of different reasons and other people who don't. And I think we all really need to give each other grace. We do. And just, your experience is your experience. My experience is my experience. And if you're having a bad experience, I will if you want my support, I will support you. And if you're having a good experience, well, lucky you.
Yeah, beautiful words of wisdom. And I think we should be flexible too, depending on whatever life stage we are. When I crossed the age of 40, I've never thought I would even entertain HRT because I work so hard on my lifestyle and what to eat. I have a food phobia. Like I'm very careful about the healthiest diet ever, and I thought, I can do it, or I can look after myself. I don't need drugs. No, I do, and I couldn't have suffered more, and things needed to change. I've come across the term bio-identical hormones during this research. It often comes up marketed as a natural alternative to the traditional HRT that we get on the NHS. What's your take on these hormones?
So that's a good question. It's a question a lot of people ask because that's what you see. These are better than what you would get on the NHS. So we make a distinction between bio-identical HRT and body-identical HRT. Bio-identical HRT basically is HRT that is generally made by what are called compounding pharmacies. They say that they make it by analyzing, usually from a saliva sample, sometimes from a blood sample, analyzing the hormones in your blood and then creating something that is identical to the hormones that they have found on testing you.
In terms of the hormone itself or the dosage?
Then that's what's not clear. So definitely the hormone, but I struggle to. I think that they say the dosage as well. But remember that, but in your body, your hormone levels fluctuate. They go up and down depending on where you are in the time of the month, for example.
Yes.
And so in order to do it, to make it truly sort of bio-identical in the way that I think it's described, you would expect to be taking different doses of hormones over the course of the month to reflect what's happening in your body. And I'm not sure that is the case. But the questions that people have about these compounded bioidentical hormones is that they're not regulated in the way that pharmaceutical hormones are regulated. So pharmaceutical hormones have to go through really, really rigorous testing in individuals, testing in the lab, lots and lots of really good quality control, randomized clinical trials where they are compared either with other hormones or with people taking placebo to be able to say this works.
Like any drug, right?
In the same way that any drug is regulated.
And this is a body?
This is body identical, which I'll talk about in a second. These bioidentical hormones don't go through that rigorous testing. This is not to say that they don't work. It's just to say that there is no proof that they work. And there is no evidence that they have been tested for safety. And that's where, so it could well be that they do work. But in the same way that pharmaceutical products, you have to demonstrate the steps that they went through to show that they work and to show that they're safe, those steps don't apply to bioidentical hormones. So that is the concern that they have with them. We don't have enough information to know whether they work or not because nothing has been published to show that they work. With body-identical HRT, so the type of HRT that you would get from the NHS, these are hormones that are produced from plants. So they are natural and they are identical. So if you did a chemical analysis of the estrogen and progesterone in your patch or your gel, and you compared it to a chemical analysis of the estrogen produced by your ovaries, they are exactly the same. Exactly the same. So that's why they're called body identical. And in addition to them being exactly the same as the hormones that your ovary produces, they have been through rigorous testing to show, one, that they are safe, and two, that they work. And that's the difference.
I don't remember a very detailed conversation with my GP when I was prescribed HRT. How do GPs prescribe? Do they start with a minimum dosage, then try that for 2 or 3 months, then see how you feel, then increase kind of thing? I can say that I responded beautifully on the lowest dosage. Is this how it works?
Yeah, that's a very, very good question. So when they do these tests to show how effective how effective a hormone is, so in the case of HRT, they start by using very low doses and then they go up. And then when they do their clinical trials or their studies, they say, oh, this dose was the most effective with the least harm. That's kind of that's the balance. And so the doses that they use for the drug to be licensed are then the doses that are prescribed. And it's usually a range of doses. So in general, most women will start, for example, if you're thinking about estrogen, with a dose of about 50 micrograms. Yeah?
Yes.
Most women, unless there's a reason to use a lower dose, for example, but in general, most women of menopausal age, so between 45 and 55, will usually start at about 50. And many of those women will be absolutely fine at 50, like you, and will not need to increase the dose. There's no evidence that increasing the dose is better. Increasing the dose of any medicine, as you will know, may increase the risk of side effects. So if you are taking a dose that works for you and doesn't cause side effects, then that is the dose for you. There are some women who start on a dose, 50 micrograms, for example, and they find, yes, I have had some improvement, but actually I'm still not quite right. And in those women, you might want to increase the dose. But you would only increase the dose as necessary up to up to a maximum dose, which was shown in studies to be effective and safe.
Which is?
So with estrogen, it's usually up to 100 micrograms. Beyond 100 micrograms, we don't have the data to show that it's safe. There are some women who may need more than 100 micrograms, but if you're prescribing more than 100 micrograms in those women, first of all, they have to understand that the data for using that dose are limited and that there might be harm. And then you have to explain to them what the potential harms might be. And then in a conversation between both me as the physician and the woman, you do a risk and benefits discussion. And then the woman may say, oh, well, the risks to me sound like risks that I don't want to take, so I will not go higher. And other women will say, yes, I hear what you're saying about the risks and benefits, but the quality of my life is so bad with with this dose, I would like to go up higher and see. And if you're going to do that, if you're going to prescribe a higher dose, then you have to monitor women very carefully. With estrogen, you have to make sure that if you're increasing the dose of estrogen, that you're increasing the dose of progesterone as well. Because estrogen and progesterone are necessary for HRT to be prescribed safely. If you give estrogen by itself, it causes the lining of the womb to build up, and progesterone counters that. But if you give higher doses of estrogen than are prescribed, you may not, and you use standard doses of progesterone, the dose of progesterone may not be enough to protect the lining of the womb. And this is why it's really, and this is where some of the controversy about high dose estrogen has come from, because in some women who are given high dose estrogen, and haven't been given enough progesterone, changes have started to happen in the lining of the womb that might predispose to cancer. And so that's why the dose balance is really important.
Okay. For those women who might need, let's say, 100 mcg or over, does that mean, and they feel better on a high dose of estrogen, does that mean that their baseline estrogen in their younger days was probably higher than other women?
Yeah, it could mean that. The other thing also is that in a woman who is sort of perimenopausal, so hasn't yet started to have a decline in her estrogen levels, her requirements for estrogen will be much greater than in a woman who is in the late perimenopause, so a woman who is postmenopausal, because we know that requirements for estrogen fall generally as you get older. You don't need it for reproduction, for example. And so often younger women who start HRT need a higher dose of estrogen than older women who start HRT. But it's again very individualized. And the majority of women don't need estrogen doses of 100 or more. Most women don't. Some women do. And it's important that women who do are not denied those doses if they really need them. But it's also important that they understand that this is an area that we don't have a lot of understanding of. And so there has to be a really close relationship, I think, between the woman and the person prescribing it to make sure that she's not being harmed.
Yeah. And for me, it was a bit tempting to pick up the phone and ask for a higher dose because I thought if I feel so much better on 50, I might feel
even better.
Amazing. On 75, no.
But we don't have data that supports that.
Okay, if I feel better on 50, leave it at that.
Leave it at 50. Because, you know, there's a principle in medicine which is why give more medicine than you need if this amount of medicine does what you want it to do? More is not necessarily always better.
Yes.
Because what you want is to feel better. And if you feel better, why are you...
Why fiddle with status quo? You're okay. Yeah, okay. Of course. The UK has experienced significant HRT shortages over the past few years, particularly around 2021 and 2023. You yourself worked with manufacturers during these shortages. What was happening behind the scenes?
So I didn't actually directly work with manufacturers, just to say, but the hospital that I work at, was in conversation with manufacturers because a lot of NHS hospitals and so on were affected by these shortages. I think that the main thing that happened was the demand for HRT went up, and it went up largely, I think, because menopause became something that people started to talk more about. Women started to recognize that they weren't going through this by themselves, that celebrities who themselves had been impacted negatively by menopause were really speaking out about menopause, about HRT, and about the benefit that they had gained from it. I mean, you yourself have talked now in this podcast about how much it helped you. So suddenly there are a whole lot of women who were saying, "Oh, I want HRT." And the thing is, manufacturers make medicines. The quantities of medicines that manufacturers make basically are in line with the demand. And if the demand has been stable for X number of years, then they have no reason to necessarily make more. And they may not be their structures may not be set up to make more. And then all of a sudden, there are all these demands, and they didn't have the manufacturing capacity to keep up with the demand. I think that's the basic reason.
God help everyone if my HRT is ever taken away from me now. Yeah, but some women can't or made the choice not to take HRT, should they fiddle with other non-pharma remedies like supplements, for example?
Yeah, no, and I think that there is no reason not to think about doing other things. You know, you yourself have talked about women who want to do things naturally, and there's nothing wrong with that. I think what is important is that the supplements that they choose are safe. And so there is, and the thing about, you know, as I said, the hormones used in HRT and have been really rigorously studied. One of the sort of problems with alternatives to HRT, so soy-based products, isoflavones, black cohosh, and so on, is that again they haven't been subjected to the clinical studies that pharmaceutical products have. But there are some data to suggest that they work, and so for most women, trying those and seeing what works for them is okay. I think if you're taking herbal remedies, it's important to make sure that they're safe, and there is something called the traditional herbal registration. So even though they don't go through clinical trials, medicines that have the THR logo at least give some evidence, some demonstration that they've been tested for safety, not necessarily for effectiveness. So looking out for that logo with herbal remedies is good. I think when you just go and get, you know, random Chinese herbs or that kind of thing that haven't been tested at all and that you're not sure what's in them, the danger with those is that sometimes they can contain components that might be harmful. So several of those types of products contain chemicals that are harmful to the liver. And so what you don't want is to be trying to fix one thing with this and then causing another problem because it contains something that you don't know about.
Yes.
With products like soya and phytoestrogen, so plant-based estrogen, which is what soya is, there are some groups of women who have to be careful. So, you know, women who have current breast cancer or a history of breast cancer, we're very careful about avoiding prescribing HRT, depending on what the kind of cancer is. But estrogen in these isoflavones, soya products, so not natural soy, so you can eat natural soya, but soya tablets where the estrogen is concentrated, they may be harmful for women who have a history of breast cancer. So the general advice is to avoid those kinds of products if you have a history of breast cancer.
Yes, I have read about a new class of non-hormonal drugs for hot flushes targeting neurokinin receptors. Are those promising?
Yeah, they are promising. So you remember when we talked in the beginning about what causes a hot flush, and I talked about this part of the brain called the hypothalamus. So this collection of nerves that is important in the regulation of temperature, so controlled by estrogen. So what happens is when estrogen levels fall, these nerves that kind of cause a problem with the way you regulate your temperature start to behave abnormally. And this new class of drugs called NK3 inhibitors or NK3 antagonists suppress these overactive nerves that cause you to have these hot flushes. And the nice thing about them is that, so they work just for hot flushes and sweats. They don't work for any of the other menopause symptoms. But because they're not hormonal, for women who have a history of cancer, they may be a better option. And one of them, a newer one, has been tested in women with a history of cancer and seems to be effective, but also not to cause problems with recurrence of cancers. So this is a new group of medicines that can be used to treat hot flushes and sweats really, really effectively, and in the majority of women as effectively as HRT, but won't necessarily do anything for the other problems that you have that are related to a lack of estrogen. But remember, we talked about things like sleep and so on. So if the reason you're not sleeping is because you're having lots and lots of hot flushes and your hot flushes are controlled, then maybe you will sleep better. So there may be indirect effects. We know that hot flushes, women who have severe hot flushes are more likely to develop cardiovascular disease than women who don't have severe hot flushes. So if your hot flushes are controlled, even if that control is not by HRT, can you reduce the risk of cardiovascular disease? We were talking about unknowns. You know, a really nice study to be done would be, can we follow women who take HRT with estrogen and who take these newer NK3 receptor antagonists and look at their risk of cardiovascular disease. And in women whose hot flushes are suppressed by estrogen or by the NK3 receptor antagonists, do they also have lower rates of cardiovascular disease? Don't know yet, but really important to know that, I think.
Yes. Nneka, you co-founded NewWoman Health. I love the name NewWoman. That's how I feel after HRT. A dedicated menopause clinic. I imagine that leaving the security of the NHS wasn't an easy decision. What frustration persuaded you to take this step?
Okay, so first of all, I didn't completely leave the security of the NHS. Okay. So I still do a clinic in the NHS. So, and just a little random aside. So I'm an HIV physician, as you said in the beginning. And my first experiences of menopause in my patients were in women living with HIV. And so I set up, with some colleagues, a menopause clinic specifically for women living with HIV. And then I started to do it more generally. But the reason that we set up NewWoman Health is because of what we'd heard from women about their experiences of menopause and about the fact that they found it really difficult to get help. Until very recently, and it's well known that medical students get get zero training in menopause. And even once you graduate as a doctor, when you're doing your rotations, you don't get training in menopause. Gynecologists, who are the doctors who generally should deal with menopause, really only get training in menopause if they choose to specialize in menopause.
This is shocking.
It is, but it's the way it is. And GPs, unless they have a particular interest in menopause, don't really get training in menopause. And so coinciding with the increased interest in women in trying to understand their symptoms and get support for their symptoms, there are all these women trying to get appointments to see a menopause, or to see their GP, or to see a menopause specialist. And there weren't enough menopause specialists in the NHS, not enough GPs who kind of understood menopause to the degree that perhaps it was necessary for some women. And so there was all this demand for menopause services. And I was hearing about it from my patients saying, I've waited X number of weeks or months to see someone about my symptoms and I don't know what to do. So on the back of that, we thought, well, maybe we should set up a clinic. But the other thing also was because, as you've heard me say, menopause is not just about HRT. It's about how you kind of optimize your life as you get older. If you need HRT, yes, but how do you think about the best way to exercise as a woman who is starting to lose estrogen, knowing how important estrogen is for the functioning of muscles, for the functioning of bones? How do you eat properly? How do you try to ensure that your life, that you're doing all the things you need to do to live healthily into the next phase of your life? And so one of the reasons for setting up this clinic was to provide a place where women could do all of those things, have access to information about how to eat properly, have access to information just about menopause and about what they're going through, have access to HRT if they want it, and so on, all in the same place.
So is this a holistic approach that I read on your website talking about?
Yeah.